Well, it looks like we have a quorum. So again, welcome everybody to the Public Health PBRN monthly virtual meeting for March. And I hope everybody is getting their first day of spring off to a good start. It's been snowing here in Kentucky of all things, so we're hoping for some improvement as we move along. We've got another action-packed agenda for everybody today. Starting as usual with our research in progress session this month, hosted by colleagues from the Nebraska Public Health PBRN, Dr. Liwu Chen and his colleagues there at the University of Nebraska Medical Center and the Nebraska Department of Health and other colleagues. So we'll, as usual, spend our first chunk of time here hearing research in progress from our Nebraska network, and then move into other active components of our agenda. In particular, we've got several guests with us here on our second portion of our agenda related to public health PBRN opportunities and administrative matters. So we're grateful to have several guests with us as well. We'll introduce those when we get to those segments of the agenda. So with that, let me see if we can turn it over to Dr. Chen and colleagues from the Nebraska PBRN.
Thank you, Glenn. Okay, the purpose of this project is to examine the relationship between QI and accreditation strategies for regional local health departments in Nebraska. And first, we would like to thank the Robert Wood Johnson Foundation for its funding support, and also thank the local health departments in Nebraska for participating in this study. And we have engaged the steering committee of our PBRN in the research.
About linking Q.
Sorry? Okay. We have engaged the steering committee of our PBRN in the design and implementation of this research. And we also want to thank Dr. Bill Riley from the University of Minnesota for providing consultation to this project. Our project team includes myself, Dave Pong from Nebraska Department of Health and Human Services, Office of Community and Rural Health, and also Ann Nguyen and Janelle Jacobson from UNMC. Dave cannot join us today, but we are pleased to have Ms. Colleen Svoboda from Lincoln. I think she's on the call as well. And Ann and Janelle will do the presentation for today's research finding discussion. Before I turn to Ann and Janelle, I just give you some general background about Nebraska and the study. As you can see on the map, it shows the public health system in Nebraska. 21 local health departments cover the 93 counties in the state. Among these 21, 17 are regional multi-county local health departments. The size of their service area ranges from 2 to 10 counties. And we have two components for this study. For the quantitative component, we used earlier survey data to examine the general relationship between QI maturity measures and accreditation attributes for local health departments in Nebraska. For the qualitative component, we conducted site visit interviews to 4 regional local health departments in the state, and also collect information about their strategies for QI and accreditation, and also explore the relationship between these two. Now I want to turn to my colleague, Ann Nguyen, to talk about the component of quantitative analysis.
Okay, the objectives of the quantitative component was to assess the current status of Nebraska's local health departments in implementing QI. We also assessed the accreditation attitudes, beliefs, and perceived readiness of Nebraska's local health departments, and we examined the correlation between QI and accreditation for Nebraska local health departments. Again, the data source that we used were the results from our local health department quality improvement survey conducted in 2011. It was developed using the QI taxonomy developed by Dr. Riley's team from the University of Minnesota. We also adapted QI maturity and accreditation questions from the Multi-State Learning Collaborative, the 2011 annual survey, and we consulted the Nebraska Public Health PBRN. So the key results that we obtained from the survey include the QI maturity results, which we used the QI maturity domains and dimensions defined by Jolie and others' 2012 study. QI maturity includes 4 domains. The first domain includes organizational culture, which refers to the values and norms that pervade how the agency interacts with its staff and stakeholders. Under the organizational culture domain, it includes 2 dimensions, including commitment and collaboration. The second domain includes capacity and competency, which refers to the skills, functions, and approach used within an organization to assess and improve quality. Capacity and competency includes 3 dimensions, including skills, methods, and investment. The third QI maturity domain includes QI practice, which refers to having ever implemented QI, the number of formal projects, and the length of time engaged in QI, as well as the use of QI strategies. The final QI maturity domain includes the alignment and spread of QI, which refers to the extent to which QI supports and is supported by the organization, as well as the diffusion of QI within the agency. And under this domain, it includes 4 dimensions, including integration, authority, value, and implementation. From the improvement survey, we also used the results that pertain to the accreditation attitudes, beliefs, and readiness. For the survey, the study population included the 21 local health department directors. 19 of the 21 local health departments responded with a response rate of 90.5%, 17 of which were from regional local health departments and 2 from single county local health departments. For analysis, we used descriptive statistics to summarize the QI maturity measures, including the items domains, which we measured as the sum of items that fell under those domains, and dimensions, which we also measured using the sum of items that fell under those dimensions. We also used descriptive statistics to summarize the accreditation measures, including the attitudes, beliefs, and readiness items. And finally, we conducted Spearman correlation analysis to examine the relationship between QI maturity and accreditation. So for the commitment dimension, these are the results for the commitment dimension. We asked the respondents to rate the level to which they agreed with the following statements. My agency leaders are receptive to new ideas for improving agency programs, services, and outcomes. All the local health department directors agreed with that. 84% of the local health departments indicated that the impetus for improving quality in my public health agency is largely driven by the internal desire to make our services and outcomes better. And another 84% indicated that the board and management team of their local health department work together for the common goals. These are the results for the collaboration dimension. 84% of the local health department directors indicated that agency data are shared with staff for performance improvement purposes. About 90% indicated that when things go wrong, their local health department looks at matters in a respectful way without blaming others. And all the local health department directors indicated that staff consult with and help one another to solve problems, as well as are routinely asked to contribute to decision making. These are the results for the skills dimension. 79% of the local health department directors indicated that the leaders of their local health department are trained in basic methods for improving quality. On the other hand, only about 52% indicated that the staff at their local health department are trained in basic methods for improving quality. Okay, these are the results for the methods dimension. I'll only go over a few of them because there's quite a few items. So 58% of the local health department directors indicated that many individuals responsible for programs and services in their local health department have the skills needed to assess the quality of their program and services. 58% also agreed that their public health agency has objective measures for determining the quality of many programs and services. And less than one-third indicated that many individuals responsible for programs and services at their local health department routinely use systematic methods to understand the root causes of problems. These are the results for the investment dimension. 26% indicated that a QI officer is designated at their local health department, and 47% indicated that their local health department establishes processes for identifying quality improvement priorities. For QI practice, 79% of local health departments indicated that their agency has ever implemented a formal process to improve the performance of a specific service or program, process, or outcome. And among those, the median number of projects was 3. Regarding the length of time engaged in QI, 47% of the local health departments indicated that they have been engaged in establishing consistent efforts to improve the quality of services for more than 5 years, 10.5% at between 3 to 4 years, 21% between 1 to 2 years, and 5.3% indicated for less than a year. Regarding the use of quality improvement strategies, 13% indicated that their local health department has never used a QI model, technique, or a metric. Another 13% indicated that their local health department has only used a QI model or a technique or a metric. And 20% indicated that a combination of a QI model and technique, or a model and a metric, or a QI technique and a metric has been used. And 53% indicated that all 3 have been used, including a model, technique, and a metric. These are the specific types of models that have been used. The most commonly used model is the lean model at 41%, followed by the model for improvement at 29%, and the Baldrige at 25%. Only 12.5% of local health departments have used Six Sigma. And these are the results for the specific QI techniques that have been used for quality improvement. Brainstorming has been the most commonly used at 79%, followed by prioritization matrix at 52.6%, and run charts at 42%. The least commonly used QI techniques include radar charts, the 5 S's, and opportunity maps. And regarding the specific quality measures or metrics, the most commonly used include ongoing monitoring at 47.4%, followed by process capability at 36.8%. Process stability was the least commonly used at 5%. These are the results for the integration dimension under alignment and spread domain. Again, I'll only go over a few of these. About less than a third indicated that their agency has job descriptions, including specific responsibilities related to measuring and improving quality for individuals responsible for programs and services. Less than a third also indicated that their staff are aware of external quality improvement expertise to help measure and improve quality. And 63% indicated that good ideas for measuring and improving quality in one program or service is usually adopted by other programs or services in their local health department. And 63% also indicated that improving quality is well integrated into the way many individuals responsible for programs and services work in their agency. Regarding the authority, value, and implementation dimensions under the alignment and spread domain, firstly, authority, 74% indicated that many individuals responsible for programs and services in their agency have the authority to change practices or influence policy to improve services within their areas of responsibility. About 90% indicated that spending time and resources on quality improvement is worth the effort, and 74% indicated that many individuals responsible for programs and services in their agency find implementing methods for assessing and improving the quality of services to be challenging. These are the descriptive statistics for the QI maturity measures. So if you look at the second column, this shows the sum of score ranges for each of the domain and dimensions. And following that column are the descriptive statistics. So if you look at the first domain, the organizational culture, the sum of scores between 7 to 35. Local health departments in Nebraska scored a mean score of 31.4, indicating that they are quite mature with regards to organizational culture. If you look at the second domain of capacity and competency, the sum of score range is between 10 to 50. Local health departments in Nebraska scored a mean score of 36.5, indicating that they're only moderately mature. So if you look at the dimensions underneath the capacity and competency domain, the low score is likely due to methods and the methods and investment dimension, indicating that there may be areas for improvement in terms of applying QI tools and approaches, as well as designating staff for QI. For quality improvement practice, 83% indicated that they have ever implemented a QI project, which suggests that local health departments in Nebraska are mature in the area of QI practice. And finally, if you look at the alignment and spread domain, the sum of score range is between 11 to 55. Local health departments in Nebraska scored a mean score of 37.3, again suggesting that they're moderately mature in terms of alignment and spread. Again, if you look at the individual dimensions, the lower scores are likely due to the integration and implementation dimensions, suggesting that there can be improvements in terms of having policies and practices in place to implement QI, and as well as changing the perception of applying methods, QI methods. Okay, these are the results for the attitudes towards accreditation. Again, respondents were asked to rate the level to which they agree with the following statements. My public health agency would seek accreditation under the Voluntary National Accreditation Program within the first 2 years of the programs. Only 1/3 of the local health department directors agreed with that. My local public health agency would seek accreditation under a Voluntary National Accreditation Program. 72% indicated that they agreed with that statement. These are the results for the beliefs, accreditation beliefs. 83% believe that having national standards for public health performance is a good idea. 83% also believe that receiving national accreditation would strengthen their public health agency. 61% believe that receiving national accreditation would improve the quality of services provided by their local health department. And 67% believe that receiving national accreditation would enhance the credibility of their local health department with their stakeholders. Okay, these are results for accreditation perceived readiness. My public health agency has begun preparing for national voluntary accreditation. Only 72% agreed with that. And as of today, I am confident in my public health agency's capacity to obtain national voluntary accreditation. Only 35% agreed with that. Okay, this slide shows the relationship between quality improvement, maturity, and accreditation. Regarding the attitudes towards accreditation, a commitment to QI and the length of time engaged in QI was found to be positively associated with the attitudes towards seeking voluntary national accreditation. Furthermore, the use of QI strategies was found to be positively associated with the attitudes towards seeking voluntary national accreditation within the first 2 years of the program. For beliefs in accreditation, valuing QI was found to be positively associated with believing that national standards are a good idea. The ability to apply QI methods, the integration of QI policies and practices, and the alignment and spread of QI within an agency were also found positively associated with the belief that accreditation would strengthen the agency. And finally, regarding the perceived readiness for accreditation, a commitment to QI was found to be positively associated with the commencement in preparing for accreditation, and the use of QI strategies and integration of QI policies and practices within the agency were also positively associated with the confidence in the agency's capacity to obtain accreditation. Okay. I'll turn this over to Janelle. She will be going over the qualitative component.
So for the qualitative component of the study, we conducted site visit interviews in selected local health departments sites to collect more in-depth qualitative information on LHD strategies and planning for QI, accreditation, and general performance management. So the purpose was to identify strengths and weaknesses in the 10 essential service areas, examine the readiness for accreditation for regional local health departments in Nebraska, and examine the relationship between QI and accreditation to inform how QI and accreditation strategies can be better integrated. So the 4 sites were chosen for variation in composition and levels of readiness. And there were 7 interviews that were completed, and these interviews were completed with directors of local health departments and then also with staff involved with quality improvement and accreditation. And the interviews were transcribed and coded for themes using QSR in vivo 10. So what we found were that most local health departments found Essential Service 2 and Essential Service 4 as strengths within their local health departments, which include diagnosing and investigating health problems and health hazards in the community, and mobilizing community partnerships and action to identify and solve health problems. The main weakness that they found in the 10 essential service areas were for Essential Service 10, which was research for new insights and innovative solutions to health problems. A lot of them felt that they just did not have the capacity in order to do research within their local health department. So one of the challenges that was experienced by local health departments looking at accreditation is really feeling overwhelmed by the process and some confusion about what was required. So one of the staff members said, I think when we first started, it was just getting the big pieces together. What really do they mean? You know, what really are they looking for when you're going to submit? I think those are some challenges because we are still not quite sure what the FAB standards and what they are asking for. Another challenge that they saw were competing priorities of existing daily tasks and staff time needed for compiling documentation. So a director indicated that most people are fairly busy managing their programs. The challenge will be having them to be able to take the time to gather their documents in conjunction with their daily tasks and to fill up the folders that we have in the Common Drive. I think the challenge for us will be for staff to have time to do it. There were also similar challenges in implementing QI activities within their local health departments, and they included competing priorities and a lack of staff time. So a director indicated that we are incredibly short-staffed. Not only are we out of space, but everybody is doing many jobs. So is this having the time? Quality takes time. It saves time, but it takes time. And we will never have enough resources. So an interesting finding that we saw was that the early, one of the local health departments was an early adopter of quality improvement activities, and they indicated that their existing quality improvement infrastructure was very helpful in beginning the process for accreditation. So the director of that health department said, we already had a firm, we were already doing a lot of stuff. So for example, there are a lot of HR stuff in FAB, and under the human resource section of the FAB standards and measures. You know, for us it was like a check, 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 check. You know, we were already doing all that stuff. So how local health departments went about addressing these challenges was really in the process of like forming teams. So they took a team-based approach to addressing accreditation QI. So a director indicated that we've had teams for a long time. All of our teams are very effective. Also, we found that the early adopter of quality improvement provided technical assistance to the late adopters of QI on accreditation. And a staff member said that's one of the health departments from the conference calls that she would get on and discuss and talk about the progress they had made. I actually called her and individually got to talk to her on the phone, and she helped me quite a bit with a plan of how to set up our Common Drive on the computer to be able to store the documents. Also, they shared existing copies of policies, procedures, and other documentation. Now we are moving to a new capability. That will be easier, share documents, and that kind of stuff. we do plan to borrow and steal anything what we can get. The local health departments believe that quality improvement and accreditations was really not separable from one another, that one led to another. I think accreditation is part of the quality improvement process for the health department. They go hand in hand. And I know you need to have a quality improvement plan to be accredited, like you need a strategic plan and the only to fit together and make sense, so it's just one piece of one big animal. And they saw that accreditation as a driving factor for them to implement quality improvement. Accreditation is showing us where we're falling down in QI. That is not necessarily a positive because it opens up little weak areas that I do not like to see, but that are there. But it is helping me see what they are and where they are. So it helps me correct that if I was not doing accreditation, I might be blind to some of these. So accreditation is helping with QI because as we go through with it, I know I'm going to see more areas where we are not doing anything. Oh my God, how could it go unattended because it has not come across in any of the programs of the staff are doing it. So we also saw that the level of readiness to apply for accreditation varies between the local health departments that we interviewed. And we saw that the early adopter of quality improvement has already submitted their letter of intent and will have a site visit in 2013. But the later adopters have some of their prerequisites done for accreditation and are planning to apply within 3 to 5 years. So some of the opportunities that they saw for quality improvement and accreditation is that it will improve local health department activities through documenting evaluation and better serving the public. Even a QI project around something like that, like fit testing respirators, it is going to tell me what the best time to get this evaluation. Those evaluations will get us set up, and that is like every program and every grant have that opportunity to look at it and get that feedback. They also saw that because there might be possible funding opportunities to those that are accredited, that would be an opportunity. So one of the benefits that had been dangled in front of us has been perhaps if you've been accredited in the future, there will be a few less hoops to jump through when you are applying for a grant. Perhaps you are not accredited in the future, you might not be able to apply for certain types of funds, and those I think would be all important. They also saw that improving QI and standardization of processes will help make their LHD better. I will say it is going to make us all obviously more standard everywhere. We all are going to be, talking the same language. We all know that we are going to have certain things that we should have. I think that to me is the biggest thing, that it is all how we all will be doing the same things. Kind of a framework of excellence. So the role of the State Office of Community and Rural Health in accreditation and quality improvement in local health departments is extremely important. By providing funding through a contract with the Public Health Association of Nebraska, they were able to provide funding to the local health departments that were interested in order for them to complete the prerequisites for accreditation, also to do a kind of self-assessment of their department against the FAB standards and measures. They also provided access to the Mine Manager software, and they've also provided a small amount of funding in order for a local health department to do a small QI plan or project. And so one staff member said, so all of those trainings last fall helped a lot. There's also monthly conference calls for a couple of work groups that we have within the state. There's one that works with policies and procedures, and there's another one that works with Mine Manager work group. So it's nice to get on these conference calls and learn from the people that develop Mine Manager software, but also when we do have our conference calls within the state, we learn from other health departments what they've done. And another director said, and if we didn't have this consultant that was hired by the state, and if you guys had not made that possible, possibly we would all be light years behind, and it has been a huge benefit. That is the end of our presentation. Are there any questions?
At this time, I've opened up the mics, so if you have muted your phone, you can unmute and we can begin with the Q&A.
I would like to remind everybody that if you are having issues with your audio, you can always type your question into the chat box, and we can read it out loud.
Well, I'll take moderator's prerogative and ask the first question. First of all, this is really really interesting work. I had the privilege of being up with the Nebraska PBRN a couple of weeks ago and got to hear in a little bit more in depth the work that's happening in these areas of looking at QI practice and looking at what public health agency actors are doing around preparing for accreditation. And so it's a really interesting mix of studies that you all have going up in Nebraska in a very interesting environment to study these issues in terms of as you mentioned earlier, the structure there in Nebraska with these multi-county regional districts as well as single county districts, and interesting in developing relationships between state and local public health. So this is great and important work. One question I had, I know that some of your findings, especially the quantitative part of this study, show some differences in terms of QI practice and kind of QI comfort level between agency leadership versus kind of operational staff within public health agencies. And I wondered if you had some thoughts about maybe why there might be those differences in QI adoption or QI capacity at this stage between the leadership level and the operational level of staff, and then what thoughts you might have about what strategies might be effective for closing some of those gaps.
Thank you, Glenn. Thank you for the comment, also for the question. Our data show that, and also from our interview with local health department director and staff, is that actually many of the local health departments in Nebraska are still in the early stage of QI development and implementation. So although I think most directors, I think they are kind of ahead of their staff in this particular type of initiative. So they have better training and also better understanding about the QI as compared to the average staff in the local health departments. However, on the other hand, I mean, the good thing is that we observe that many local health departments, they are highly interested. I mean, even at the state level, they are very highly interested in developing more QI initiatives and also implementing QI. So they are interested in receiving training. We also, our quantitative data, survey data also show that. I mean, as well as qualitative data also show that. So that's our observation. And Colleen, maybe you can comment more on this question.
Can you hear me?
Yeah, sure. Yeah.
I absolutely agree with what you've said, Li Wu. I think this research really leads us into training opportunities, and we can use a lot of what has been found to get into that workforce development piece in the practice world. So I'm excited in our office to take the results and move forward that way. And I think you're absolutely right. The training just hasn't filtered down, I don't think, to the local health department staff as much as it has to those health directors.
Thank you, Colleen. Yeah.
Glenn, this is Elaine O'Keefe. I'm sorry, I got knocked off, so I'd like to ask a question, but I don't want to jump ahead of others who may be.
No, I think you're right. You're right on time. So go right ahead.
Oh, thank you. Okay, this is Elaine from the Connecticut PBRN, and one question I had, first, I thought the study was very interesting, and I mean, I guess some of the results would be predictable in like state of readiness or perception of readiness to go for accreditation now or 2 or 3 years down the road, looking at the QI experience. But my question is, in Nebraska, I don't know that much about the structure of your local health departments? I mean, you've talked about it a little bit on this call, but did you look at all at differences in responses, relationships, the characteristics of the health departments? I mean, did you have, I don't know if that was part of the study, looking at the capacity of departments, their size, resources, and so on?
Originally, we tried to see whether we can do a comparison between multiple county and single county. But as you know, the sample size is very small. So only 2 single county departments respond to the survey. And our interview component focus on regional local health departments.
Right.
But I think this is a very good point. We did find, I mean, the variations pretty much from the regional local health departments, and we certainly find that some local health departments we define as early adopter of QIs, and we found those departments that are certainly better staffed and more resources, and they have designated QI officer and multiple QI project teams. And so there's that difference between local health departments, I mean regional local health departments. But because of the small sample size, we could not do a very thorough comparative analysis about this issue.
I'm sorry, could you tell me again the sample size? I guess I missed the first part of that.
Sample size, we have 21 local health departments in the state. We sent out the survey to all of them, and 19 responded. Among the 19, 2 are single county, and 17 were regional multi-county local health departments.
Thank you.
Sure.
Just to follow up on that question, Elaine's question made me think again about the fairly unique regional structure that you have in Nebraska. I wonder if you gained any insight, maybe through the qualitative component, about how these multi-county regional departments are actually approaching QI, QI capacity building, or how they are approaching accreditation preparedness on a regional multi-county level. Do you have any insight into how that's working, and particularly thinking about some of these districts that are fairly large, that as you said, can have 2, 3, 4 or more counties. Thinking about how you implement an innovation like QI, or like preparing for accreditation across a fairly large area, potentially multiple communities. Do you have some insight about how that actually plays out in these regional structures?
Yes, we actually found that the national accreditation did provide a very good opportunity for these regional local health departments to engage in their community partners in establishing partnership within the regional district. Some example including the prerequisite for the accreditation. So we found in some local health departments, the district, they have been, because the requirement from this is a prerequisite for accreditation, so they need to do community health need assessment and also health improvement plan. So some regional local health departments, they have really moving forward significantly in those areas, and really kind of mobilizing the partnership with their community partners, and did a very good job, and very comprehensive community health need assessment already conducted by some of the regional local health departments. And I do think that it's kind of like what we found, the relationship between QI and accreditation, and also because this accreditation opportunity does provide good opportunity for this regionalization of partnership to become stronger, and that's what we found from the field. Colleen, you may also want to comment on this issue as well.
I think you are right on, Li Wu, especially in the piece about collaboration. The local health departments, I was trying to think of how I would answer this question, and I thought this is just the way that those departments have to do business. it's hard to answer that question because that's how they operate. They collaborate. They have to collaborate with their partners so well in order to do business in such a large region, that they bring that collaborative spirit to everything that they pursue, including quality improvement or preparation for accreditation. So their QI teams include partners from around their region, not just people on their own staff, as one example.
Fantastic. Is there another question from our audience?
Glenn, am I on mute or can you hear me?
You're on. We can hear you.
Terrific. This is Lisa from Colorado. So hi, neighbors in Nebraska. This sounds like really terrific work. I apologize, I'm not on the computer to actually see some of the, to see the slides. But so you can tell me if this question is answered if I just review the slides. But I'm interested in what you just mentioned about the interconnectedness between QI and accreditation. And I mean, in my head, it's not really a chicken egg. It's sort of, it is interconnected, but I suspect that there's different ways to approach and engage both staff and community members, and you could approach it sort of from either perspective, starting with QI or starting with accreditation, or I guess starting with both. And I'm wondering if you saw any trends in those that were either more advanced in either. What was successful in terms of rallying the staff around, we're going to go forward for accreditation, and by the way, in order to do that, we're going to have to do QI, or rallying staff with, we're going to do QI, and by the way, that's going to prepare us for accreditation, or some other way to approach it?
Sorry, I'm trying to understand your question. So your question is, again, I mean, how they proceed with QI and accreditation in terms of sequence, and how the relationship of these two, is that?
Exactly, yeah. So the ones that you saw that were a little farther along in either respect, did they always, were there any trends around where they started the conversation within their health department?
I think this is what we found. You know, for the early adopters of QI, we define that their comfort level and also confidence about, you know, accreditation preparation is much higher than those late adopters of QIs. And I think that does make sense. And also from their the quotes, they say, I mean, the accreditation is part of QI. That's their comment. And so I think they have already been doing relevant tests associated with accreditation. I mean, they've been doing QI for quite a while. But for the late adopters of QI, we define that although I mean, our research showed that they feel overwhelmed by the accreditation process, given its complexity, and also the challenge about competing tasks, lack of staff time. But at the same time, we define that they also found this accreditation provide them with a good opportunity to motivate their staff, the local health department, and establish partnership with their community partners to engage in QI. So there's that kind of relationship. I mean, I think this is what we found is a positive correlation between these two. I mean, in terms of strategy development. Yeah. I don't know whether I answered your questions.
Yes, that was great. Thank you.
Okay, thank you. Yeah.
Fantastic. We're just about the end of our time for this segment. One thing I just wanted to, I guess just to comment. I know that you noticed early on in your presentation that you, I think, smartly collaborated with a couple of other colleagues, and in particular, using an instrument that was developed through the Multi-State Learning Collaborative. Also an instrument that the Minnesota PBRN has used heavily in a couple of their QI-related studies, both at state and local levels. And you also incorporated the QI taxonomy work that came out of the Minnesota PBRN. So I'm hoping that perhaps in the future you might have teed up an opportunity to do some comparative analysis, comparing your results in Nebraska to the results using some of those same items and same measures up in Minnesota, to kind see where some of the commonalities and differences are in two states with fairly different structural characteristics in terms of the public health system.
Thank you, Glenn. Yeah, thank you for the comment. We will certainly hope to do that in the future.
Fantastic. Well, again, thank you, Dr. Chen, and to all your colleagues. Great work in Nebraska, and we'll look forward to continuing to learn from the work that you all have underway up there. So with that, let's proceed ahead on the rest of our agenda for today. We have we've got a full slate of agenda items for our kind of the administrative component of our meeting today. First, just a couple of quick updates on PBRN-related meetings and events. We obviously have our grantee meeting coming up in a couple weeks here in Lexington, Kentucky, April 8th and 9th. We're looking forward to seeing everybody there as part of that meeting and as part of the larger Keeneland Conference. We did send out the latest draft of the meeting agenda. It was attached to the announcement for this meeting that was sent out a couple days ago. So if you haven't taken a look at that yet, you can we encourage you to do that. This slide kind of gives some highlights of our day. We'll spend a little time talking about the state of our overall PBRN program and some of the major accomplishments over this last year, what we've learned from PBRN research over this last year. We'll have a couple of sessions talking about emerging research opportunities that are particularly relevant for PBRNs, including work in injury prevention. As we talked about last month, we've been engaged in a series of conversations with the CDC's Injury Center, and we'll actually have several staff from the CDC National Center for Injury Prevention and Control with us to help us with that component of our agenda, to talk about opportunities for PBRN research in the injury prevention and control space, and some opportunities for collaboration with CDC. We'll also have a session that's designed to help us think collectively about some of the opportunities that are at hand in the NIH's portfolio in dissemination and implementation science. We've talked about this opportunity the last several meetings, and as you know, NIH has recently, back in January, reissued their call for research in this area of dissemination and implementation research, with a particular emphasis, a special emphasis in D&I studies in public health settings. D&I studies looking at public health interventions and public health strategies, and so there are really a number of aspects of the kind of research that NIH is looking to fund in this current round that we think are particularly leave PBRNs in a particularly good position for. So we're going to spend some time talking about that opportunity and doing some visioning together about what multi-network research opportunities in that space might look like. On that front, we are going to send in advance of our grantee meeting. We're going to be emailing out to you some reading material to help prepare for that discussion in particular, including the RFA and a couple of other articles that can help shape your thinking around exactly what this field is about as D&I research, and how it connects with PHSSR, and how it potentially connects with PBRNs. And so be looking for that, and please make every effort to review those materials in advance of our getting together on April 8th, so that we can have the most productive discussion that we can. We'll have a working lunch, talk about a couple of other research opportunities during lunch on that Monday, and in the afternoon we'll spend mostly in breakout sessions on some important topics of research areas of common interest to PBRNs. We'll have a breakout session on our improved work, our improved networks getting together, and some other breakout sessions as well. So it'll be an action-packed agenda. Again, more details are in the agenda that we emailed out to folks a couple days ago, with the rest of the content for today's talk. So please take a look at that. Let us know if you got questions or comments or further ideas as we move closer to our grantee meeting. Before we go into our next item, we do have a couple of emerging research opportunities to talk about. I did want to remind folks of a couple of other things on the horizon related to PBRN work. One is we'll be sending out a separate email on this as a reminder as well, but we do have a quarterly PBRN skill building webinar that's coming up next Friday that will be on the topic of cost measurement and analysis that will be of interest to many of our PBRNs, I'm sure. And so we want to make sure that that's on your radar as well. That'll be next Friday, March 29th, I believe. Will include several PHSSR researchers, along with myself, kind of doing an overview of cost measurement and analysis methods, talking about some of the issues in applying those methods to public health settings, and looking at a couple examples of where these methods are being used already in PBRN research and in the larger field of PHSSR. So many of you have just gotten through with a proposal development process on this topic as part of our delivering cost study RFP solicitation. Those proposals just came in yesterday. So this topic is particularly timely for those of you who are interested in that opportunity. For those of you who are interested in the D&I opportunity at NIH has a major focus this year on cost and cost estimation. And it's obviously just an increasingly important topic for us in public health research. And so put that on your radar next Friday, our skill building webinar on cost measurement and analysis strategies in public health. There's just before that, March 26th, which I think is Tuesday, there's a webinar that Academy Health is sponsoring that involves the topic of traditional and new methods for research dissemination. That is going to be very, very interesting. So another session that you're not going to want to miss. It's free and open to all interested parties, including all of our public health PBRNs, talking about traditional methods of dissemination like journal articles, but some of our non-traditional methods as well. Blogs, media venues. We'll be talking a bit about the Frontiers vehicle that we've developed. Yeah, it's a webinar you won't want to miss. I'll be a part of that. One of the speakers, David Kindig, who edits the public health, the population health blog, will be a part of that. We also have a blogger and new media expert from the Washington Post who'll be a part of that webinar as well. March 26th, next Tuesday, 1 to 2:30 p.m. And a few other updates at the bottom of our agenda. We sent out a few other reminders on deadlines. The deadline for applying for the PBRN scholarship to attend the Academy Health meeting in the Public Health Systems Research Interest Group meeting is coming up on April 1st. So that's just a little over a week away. So make sure that's on your radar. Great opportunity again for getting our PBRN stakeholders engaged in the larger enterprise of PHSSR through Academy Health. So just a few other updates to keep in mind. So with that, let me move us to our next agenda item. We have our next two agenda items really deal with emerging research opportunities that are at hand for interested public health PBRNs. And we have a couple of guests with us today who are going to talk about a couple of these opportunities. And I think starting with Dr. Deborah Porterfield. Deborah, are you with us?
Yes, I'm here.
Fantastic. Well, thank you so much, Deborah, for joining us. Dr. Porterfield is a scientist at the Research Triangle Institute, based in Durham, North Carolina. Well-known, very large, very productive public health research institute affiliated with the North Carolina universities, UNC and Duke NC State, and a long history of doing very good applied public health research work. And Deborah has approached us with an opportunity that certainly looks to us like will be very much of interest to our PBRNs. And so Deborah's agreed to join us today and talk a little bit more about this project. So I'll turn it over to you, Deborah.
Great. Thank you, Glenn, and thank you for the opportunity to speak on this call. This is the first time I've attended one of these calls, although I'm recently become more affiliated with the North Carolina PBRN, so I hope to be on these calls in the future. And I have to say I've never seen a call start and stop with the agenda items, the timing exactly right. So I'll be sure I'm starting at 1:55, and I will not go over to keep you all on track. So again, thank you. Let me just also say, in terms of introductions, I've been at RTI for about 5 years, but before that I was at the North Carolina Division of Public Health, where I was a chronic disease director, and I'm a public health physician by training. As Glenn said, I'm at RTI. I also have a collaborator on the phone, Amy Topaitis, who is an organizational researcher at RTI, and her background is in capacity building for AIDS services organizations in New York City. So together, along with our colleague at University of Colorado, Danielle Varda, many of you are probably familiar with Danielle's work from Community conferences and other, but she's an expert in social network analysis. So we're here today to tell you about an opportunity. We would love to recruit a PBRN to work with us on a study, which is to use social network analysis to examine systems of care for persons with or at risk for HIV. Hopefully you all have our one-pager. The purpose of the study is, and I'm going to go through with a few sidebars. The purpose of the study is to examine how public health, primary care, and community organizations work together as a system to identify, enroll in care, and follow HIV patients. The context of this, of course, is the recent IOM report and our national focus now on integration between public health and primary care. My background is actually in chronic disease, but working together with Dr. Topaitis and others, I think we've formulated a study idea in the field of HIV. Nowhere else is this issue of integration probably more urgent or critical. We know that the lack of coordination between the organizations that are responsible for the screening, identification, and those organizations providing the primary care is contributing to late diagnosis, delayed entry into care, and poor retention in care for significant numbers of persons. So that's our context. We also know from recent research that an extremely effective strategy for preventing new cases of HIV is the timely initiation of antiretroviral therapy in the known patients of HIV. So this again underscores this critical linkage between treatment and prevention.
Sorry about that. It looks like we're having some audio issues. If you have your phone on, could you please mute your phone?
I'll just keep going if everyone can hear me. So also just as further context, this issue of the lack of integration, again, it's just recently made the literature, I should say, in the field of HIV. There's a couple recent studies. There's a HRSA demonstration project specifically trying to enhance the linkages, but there's been very little descriptive work done on what are these systems of care. So we think this is an area where this concept is, again, urgent and critically needs to be studied. So our approach, we'd like to identify a PBRN to be a full partner in the study. Our current concept of study design is through the PBRN, with the PBRN, to identify a sample of 4 local health departments. We're intentionally starting small. I write here that this would be based on outcome data. That's ideal, and I'll, in a second, identify for you what we're thinking the outcomes are. But again, I think the beginning exploratory step, it might even be just to identify 4 health departments who are interested to work in this field. Moving forward in terms of the approach, there would be planning meetings, in-person, on-site planning meetings with the health departments. And again, we'd like the PBRN to participate in that. And to, again, the PBRN's role to participate in interpretation, write-up, and dissemination of findings. We would need, especially for working in a state that's not North Carolina or Colorado, for the PBRN to help to be the liaison to the state health department for that outcome data. And the PBRN, we hope, would also help to identify what we hope will be a resource if the findings support this, a resource that can be disseminated and used by other local health departments. So again, up to 4 local health departments to be recruited. These health departments would be asked to identify their partners in their systems of care for persons with and at risk for HIV. And the goal that all the organizations will participate in a web-based survey. So then these are the specific steps, again, to meet in person with the health department and key partners to identify those organizations so that they are identified in a standardized way. Also importantly, we have our ideas about measurement, about the variables, about how we're going to measure these systems and networks, but we really need the on-the-ground brainstorming in terms of what the health departments and the partners think are the key features of an effective network, and that certainly can and will influence measurement, the actual survey. So then the next step is this web-based survey, and many of you are probably familiar with Dr. Varda's partner tool, which we would tweak for the purpose of this study. The next step would be really descriptive analysis. I don't have that here, but really it's a descriptive analysis, and those of you, again, who've seen Danielle's work, the picture is worth a million words, but also, you know, there would be the standard and to be developed social network analysis metrics that we would use to describe these networks. And then, as the data allows, a quantitative analysis to determine which key features of the networks are related to the outcomes. Finally, providing follow-up webinars with each of the health departments and key partners to explain the findings and encourage a quality improvement approach. And Danielle's term for this is strategic network management, to use the study findings to improve the structure and functioning. Some of you may be aware, Danielle is offering I think it's a webinar series this summer specifically on strategic network management. And a particular focus area of her work is not just the research aspect of it, but also then how to use this data to improve the functioning of the network. So the state health department would also ideally be involved as a study partner or just as a cooperative partner to assist in the planning, implementation, interpretation of findings, and to provide the outcome data. Now, I've mentioned outcomes a couple times, and it's in the next paragraph. There are 3 outcomes that we think would be ideal for this work, and our understanding is that it's available with some effort, with some analysis would probably be needed by the state health department partner. And these are all outcomes that are recommended in a 2012 IOM report on measuring the quality of HIV care. So those are in that next paragraph. They are the proportion of HIV persons in a county who are in continuous care, proportion of newly diagnosed persons with a CD4 less than 200, so that's an indicator of late diagnosis, and proportion of newly diagnosed persons with HIV who are linked to clinical care within 3 months of diagnosis. So that last one is actually what we feel is the critical outcome of interest. So the last little bit there is just, the contributions we feel this will make. How can this data be used by the local health department and the partners, ideally, to strengthen their systems of care, by the state health department to inform technical assistance, and by researchers such as in this group in the broader field of systems of care for HIV or other content areas. What I don't have on this one pager is kind of the funding and what we're thinking about that. Did apply for this most recent RWJ, our request for proposal. We were not invited to submit a full proposal, and I'm hoping that's mostly because we didn't have the partner, the public health partner, lined up at the point of submission. So I think that with identification of partner and further development, the plan is to resubmit for the next RFP if it's appropriate, but then to move forward, and we've already started looking around for other sources of funding. So I'd be happy to take questions as time allows, and then let me just point out my contact information is there. If there are several PBRNs that are interested to talk further, we might either talk to you individually, or since many of you probably have the same questions, we could organize a call with everyone together. Are there any questions that I can answer now?
I just want to point out, you received all of this information in an attachment to the email invitation to this call, so you can always refer back to that document, and there's contact information on that as well.
If anyone is having challenges with your microphones and you have questions, please feel free to raise your hand on the top navigation bar or type your question in the chat box. All right, I think that seeing no questions, I think we will thank Deborah for joining us today. This sounds like a terrific opportunity, and I'm sure some of our PBRNs will review the handout and be very interested in linking up with you. We would certainly here at the Coordinating Center be happy to facilitate a call. We can coordinate it through Adobe Connect or another means if necessary. So as folks have a chance to review that information and think about what Deborah has shared today and want to contact her and let us know that there are some connections being made, that would be terrific. This is Anna, by the way. I'm going to take over the MC duties for the next moment or two because first I need to let you know that Lynn Jenkins of the CDC Injury Center will not be joining us. Rather than joining us today, she and her colleagues are actually going to be at the PBRN grantee meeting, as Glenn mentioned earlier. They have a slot on the agenda. We're going to explore some possible opportunities for PBRN research to inform injury center initiatives, and I think that's going to be really exciting for everyone. We also, as you know, are going to spend a lot of time at the meeting talking about dissemination, translation, those kinds of issues, which of course, as a communication researcher, I find incredibly exciting, and we're very happy to have with us today folks who have an interesting pilot opportunity to explore dissemination and implementation science, perhaps through PBRN. So right now, I am going to turn the mic over to, I think Alicia Cohen is online from the College of Communication and Information. Margaret. Just Margaret? Okay.
Yes.
And Margaret McGladrey, who's representing the Kentucky Prevention Research Center and is the Assistant Dean for Research here at the College of Public Health. So Margaret, take it away.
Hi, everyone. Thanks for the introduction, Anna. As Anna mentioned, I am the administrator for the Kentucky Prevention Research Center, the CDC-funded Prevention Research Center. And my particular Prevention Research Center is really focused on HPV vaccination and prevention of cervical cancer because of the increased burden of cervical cancer that we experience here in Appalachian, Kentucky, specifically eastern Appalachian, Kentucky. So we've developed over the course of the last 4 years of our funding, and we're going into year 5 of our funding now, a DVD intervention designed to facilitate uptake of the second and third doses of the HPV vaccine after the first dose is delivered. So the idea is that this video is shown as folks are waiting to receive their first dose of the vaccination in order to really prime them to come back for the second and third dose. And it's been found to be very efficacious. The results of the trial of this DVD intervention were just published in the Journal of Communication. The name of this intervention is 123-PAP, as in 123 vaccinations and the PAP test to prevent cervical cancer. And it was originally designed to promote HPV adherence and age-appropriate PAP testing among young women in Appalachian, Kentucky, but this DVD intervention is adaptable for other at-risk populations and community settings. And I'd be happy to send along a link to the article if anyone is interested in seeing the Journal of Communication article that describes the efficacy trial and the results of that. And we'll begin with a presentation here with this particular research opportunity to allow all of the PBRNs to uptake this particular opportunity in their research networks, and will provide all kinds of support to different PBRNs who are interested in implementing this DVD intervention in their own setting. So we'll provide a presentation where you'll actually have the opportunity to see this video intervention with Dr. Cohen, who's the communication specialist who is charged with developing this and really filmed all the segments and would be providing technical assistance to any PBRNs who are interested in this opportunity. And we'll be presenting that at the lunchtime session of the pre-conference to the Keeneland Conference for the grantees, the PBRN grantees. And it will provide PBRNs and affiliated PRCs with the tools and consultative resources needed to adapt and customize this video intervention to your populations and community settings. And after the interested PBRNs have been identified via this pre-conference on April 8th, investigators as well as the director and deputy director of the NCC will host a one-day training session. We're planning on hosting that in Denver, Colorado, in which we'll launch the dissemination project and orient all PBRN representatives to aspects of the implementation project, from formative research and filming customized supplementary videos to the design of studies that address dissemination and health systems and services research questions of interest to the PBRNs. And we had listed out in that email that Lizette had sent around prior to this webinar a list of some of the questions from the PHSSR agenda that we thought would be really relevant to PBRNs who would be interested in implementing this particular project and exploring dissemination questions. And those kinds of questions include things like what strategies are most effective in enhancing the adoption, implementation, diffusion of research-tested public health strategies among public health practitioners and policy decision makers. And we'd also be looking at other questions related to dissemination effectiveness. So there are a lot of opportunities surrounding this dissemination of this particular intervention, I think, for PBRNs who are interested in pursuing dissemination research opportunities and looking at some of the PHSSR agenda questions that we've identified. So after this one-day training, the PBRNs would have access to Dr. Hoover, actually, as a consultative resource to help you with adopting the video intervention. And we'd have Dr. Cohen as the communications specialist available to travel to different PBRN research sites that are filming new customized videos to assist with your implementation efforts. We'll also develop a web-based implementation toolkit that provides resources for implementation efforts, hold monthly webinars for all participating PBRNs. And our plan is also to purchase a special issue supplement of the American Journal of Preventive Medicine in order for PBRN representatives to publish pieces on the dissemination of this particular intervention. So we'd like to have a special issue of the journal specifically targeted toward reporting on the results of this dissemination project. And at this point, we'll present more of the details of what this specific video looks like. We'll show the video and present some of the information about what the actual implementation would look like for you at the lunchtime meeting on April 8th. But in the meantime, so that we know how many copies of the DVD to create and also how many copies of the Journal of Communication article to print and prepare and bring along on April 8th, it'd be really helpful for our planning purposes if any interested PBRNs could contact me. I can go ahead and type in my email address on the chat function here of Adobe Connect. Go ahead and get in touch with me to indicate your interest, and we'll get you on the list and make sure we have suitable information for you at the April 8th meeting. And I'd also like to take any questions that folks might have about what this opportunity would look like and what we're proposing. Just so everyone knows as well, there would be resources for travel, for PBRN representatives to travel to the Denver training, as well as support for focus groups and support for our investigators to come to you, consultative resources, and pretty much everything you'd need in order to implement this project in your setting. So I'd be really interested in hearing any questions that you all might have, and I'd like to hear from you all before April 8th if possible.
Are there any questions out there for Margaret?
Hey, Anna, this is Nancy Winterbauer in North Carolina, and I just typed in on the chat, but it would be helpful to have a kind of a short summary of this that we could share with our network in advance so we can get feedback from our partners.
Terrific. Margaret, I think we sent out a very small overview of this maybe yesterday, but we could probably put together a one-pager that would maybe be a little bit more of a marketing item, so to speak, for the networks. I think this is going to be an interesting opportunity because it will be a chance, some networks may elect to participate whole cloth and tailor the video for their particular constituencies, their demographics, and as Margaret mentioned, that they will be providing some support for that. And then we may have some networks who just use the video as is, and then we may have some networks who don't participate. So that gives us an opportunity to look at really 3 different conditions across the PBRNs to see what may be the most efficacious approaches to that, to see whether the efficacy of the video holds across those different conditions. So I think this is really an opportunity for us to start laying the groundwork for some of that DNI, geographic variation, demographic variation discussion that we're going to be starting at the PBRN grantee meeting, and see how we might be able to move forward for perhaps a multi-network DNI application in the future. I think this is a great, the timing for this is really terrific for us to start thinking about how to put those pieces together in a way that makes sense from a research perspective. Are there any other questions? Hearing none, well, Margaret, you and I can work together on just a one-pager that might be just a handout across the networks to try to get out to folks in the next week or so that you have those in hand before the PBRN grantee meeting.
Excellent.
I would also remind everyone that that they are going to be presenting at lunch. For those of you who are concerned about the video at lunch, that was the first question I asked, was is the video appropriate for lunchtime viewing? And I'm assured that it is. So
yes,
I
yes.
Margaret implicitly. All right. Thank you again, Margaret, for joining us, and I'd like to thank Deborah again for joining us. These are some terrific opportunities, and I know we're really hoping that the PBRNs capitalize on these in terms of expanding research horizons and trying to figure out how we can work together across networks as well as within networks. All right. Lizette, if we might move on to the next slide. I know that Glenn has already covered a number of these items, but just to punch them one more time, there is the Academy Health PHSR webinar next week on March the 26th. And then, of course, that quarterly training webinar on cost estimation methods will be on March 29th. I know that several of you have submitted applications for the delivering cost studies mechanisms that closed yesterday. We'll be in touch soon. As you know, it's always a little bit of a process sorting through all of that and getting reviewers in place and doing internal screenings and all of that. So we'll be in touch with those of you who applied for that in the next few weeks. Again, Glenn mentioned the Academy Health annual research meeting and PHSR interest group scholarships. This is a terrific opportunity that Academy Health has given us to build capacity within our networks, and I really hope to see a lot of you taking advantage of it. It's not every day that Academy Health says here are a set of scholarships for travel dedicated simply to this one group, and they've done that in this case. So really, I hope that we're all able to take advantage of that. All right, we've also got the grantee meeting. Please have a look at those program agendas. It's pretty packed. It always is. If you see something missing that desperately needs to be there, give us a call, shoot us an email. We'll see what we can do. We'll try to fit as much content in as possible without having everyone with smoke coming out of their ears by the end of the second day. I do want to remind everyone that registration for the grantee meeting and registration for the Keeneland Conference were 2 different things. We didn't ask you to register for the grantee meeting just to let us know you're coming. But for Keeneland Conference, there is that registration process. There is a registration fee. And lunch, the launch lunch for the Keeneland Conference on Tuesday at noon is not covered by your attendance at the grantee meeting. So if you're planning to stay for that lunch, you need to make sure to contact those folks. I think that the PHSR Keeneland Conference late registration process is open right now on the website.
It's open, but it's not on the website. So if you do need to register for the Keeneland conference, please send us an email and we will send you a link for that.
Thanks, Lizette. So be sure to contact Lizette if you need to register late for Keeneland conference. If your plans have changed and you find that you will be staying through lunch on Tuesday and you want to do the one-day registration, I think that's probably still an option as well. And then, of course, the Academy Health Research Meeting, for which the scholarships apply, June 25th and 26th in Baltimore, and the NACHO Annual Sharing Session in Dallas is coming up in July. We've got an action-packed few months ahead, as Glenn likes to say. All right. Do we have any other items we need to cover, Lizette? Or is that the last slide?
That's it.
Terrific. If Glenn or Lizette have anything to add at this point?
I just want to appreciate everybody who's gotten back to me about their attendance at our annual grantee meeting. We have quite a full house, so I'm very, very pleased that so many of you were able to send your representatives in light of our tight budgets and all of that. So I'm very, very appreciative, and thank you so much for letting me know.
And I would add my thanks to that as well. I think we're looking at more than 60 people this year, which I think is even more than last year. And those of you who were there last year will be happy to know that we're upstairs in the ballrooms this year. If anyone has any questions or concerns between now and the annual meeting, please let us know. I again want to thank Deborah Porterfield and Margaret McGladrey for joining us to talk about these terrific opportunities. We look forward to seeing Margaret again at the PBRN grantee meeting, as well as our friends from CDC to talk about injury prevention opportunities. Thank you all so much. And with that, unless Glenn has something to add, I think we can end just a few minutes early. You found 8 minutes in your day. Spend it wisely. Have a great day. Thank you.
Thank you.